thank you so much indeed. Thanks very much for the wonderful invitation. I got a little timer here, so we get about 2.5 minutes they asked me to do a little contextualization. I'm Axel Kehner, I'm a professor in health services research at Shell University. It's a small medical school in Lancashire, just outside Liverpool, and I'm absolutely delighted to be here. Do we need a microphone? Okay, all right, okay, so I'm trying to stay here, not to walk around. Okay, and so we said, okay, well, let's look at what AI is, and let's try to get a quick context of this. And Stephanie said, oh, well, we're experts. And then I was thinking, this has only been around 2 years, you know, how can we be experts in this? But thanks very much, Stephanie, of course, you know, so. Right, okay. What I find absolutely fascinating, much of AI goes back to this guy. I don't know if you remember, but I kind of like remember my study days, literary theory and semantic and semiotics and all this sort of thing. Ferdinand de Saussure, he thought about this years and years ago. You can see this as a black and white picture. You know this is long gone. And he thought about the semantic field. And at the time, of course, there's much more philosophy and theory behind this, and I'm not going to go into that. But the simple idea was actually quite captivating. It said, like, well, every word we speak actually enters a relationship with the next word we speak, and the other words that are in the same sentence, and so on, and so on, and so on. And interestingly enough, he also said, as we are speaking more words, the semantic field becomes denser. At some time as well, okay? So he called it aura, the distance between words. We have different ways of talking about this now, but the semantic field is actually at the bottom of it, and AI is nothing else than actually a mathematical formula to make sense and to calculate the semantic field, the distance between words. And we had to wait 120 years to actually get a mathematical formula for that. And that is the magic of AI. Now, what do we mean by this whole semantic field? Let's do a little, very, very simple example. So, simple example, what do they have in common? Can I ask a friendly face here in the front, maybe? Can you tell us, what do they have in common? Just say out loud.
They have a furry. They are furry.
Fur, great. Maybe one more thing to add.
It's a kitty cat.
Oh, cats, they're cats, absolutely. There's a Latin description for that, isn't there? Don't ask me which one. All right, so we already have 2, and I'm sure we can find 5, 6, 7 different similarities in this, you know. Brilliant. Okay, now, that's the distance between these 2 things, all right? It's nothing else. The question is, how do we mathematically demonstrate this and model this, okay, and measure this? Now, let's make it complicated. This is an example I got from a BUC lecture, actually. It's not my example, but I love this example. So what's the similarity? What do they have in common? Can I come back? Well, no, you already said something. Can I come back to you? What do you think?
They both in a house.
Okay, yeah, so for example, yeah, absolutely, yeah. Any other ideas? We're really struggling, aren't we?
They're both organic matter.
They're what?
Organic matter.
Organic matters, yeah, become very general now. Yes, absolutely. They move, great, wonderful, okay.
Different sheets of bread.
They have different sheets of rock. We do get some similarities, but you can see we're actually moving away, we're moving into generalities now. And we can all think of this. When I saw this, I thought of it, well, actually, they all produce heat. They turn, actually, carbohydrates into heat, you know. Or energy into heat, okay? In this case, it's electric energy, of course, power. All right, okay. So why is this so important? Well, it is important because it tells us why it took so long to develop a large language model. It took so long because we didn't know how to describe, mathematically, how to describe the distance between things, okay? And what it means is the distance between tokens, we talk about tokens, is the direction in which they are apart from each other, and that needs to be calculated, and that's what large language models do. Now, why, if AI is so simple, we use a vector for that. Why do we have it only now? Well, because a machine cannot attach any meaning or relevance. When I showed you those pictures, you instantly thought of certain similarities. And when we have a conversation, you also think of certain similarities, and you talk to me and I think, oh, well, I understand that instantly. Maybe I don't. Maybe I don't understand it, then I ask again. But a machine doesn't have that idea of relevance and meaning, okay? And that's why it's so important, and that's why it was so difficult. Why something is of relevance, i.e. which semantic field is of interest, is something that a machine is oblivious to, and it's hard to predict, actually, okay? And that's why it's so difficult. I'll stop here. That's large language models in a very simple language. And I pass on to Sam.
Thank you, Axel, for that. And it's actually some of the things that you mentioned are some of the things that we've had to consider in our research as well. So I'm Sam Martin. I work mainly at the lab, so the Rapid Research Evaluation and Appraisal Lab at UCL. I'm also a consultant working with the Oxford Vaccine Group and the Ethox Centre, so the Oxford Big Data Institute as well. So together we're looking at evaluation of free text data and the questions that we can ask of them, of that kind of data in public health settings. And one of the things that we've been looking at is what are the commonalities and the themes that we can have a look at in terms of the free text, and also the issues of looking at sentiment analysis and how, when we're using AI models, we have to think of them as tools. So at the very beginning of this conference, people were talking about, well, AI won't save us, and of course it won't, but what we can do is use it as a tool to make sure that we can find good insight from all of this data that we have, all of these amazing dashboards that we're looking at. What kind of valuable insights can we gain from this? And that's what I'm going to talk to you a little bit about today. So at Real, we are quite a diverse group. We have many, many different skills. So we've got medical anthropologists, we've got social scientists, social epidemiologists, mixed methods people, geeks like me in digital analytics, Wellcome Research Fellows, my colleague Emma as well, who's working with me on the maternity data sets that we're looking at as well. So we have quite a lot of interested minds, and this is just a snapshot. We actually have many more than this. But together we ask complex questions from the AI tools that we use. And through this, I mean, my journey with Real started at the beginning of the pandemic. So I took a leave of absence. I was working at the London School of Hygiene and Tropical Medicine, and I tried to stay unemployed. But then at the beginning of the pandemic, I got contacted by my colleagues at the Oxford Vaccine Institute, and they said, look, we have lots and lots of interviews that we've done with healthcare workers working on the front line, and we need you to use big data methodology skills to analyse this data, and also to take this data and re-synthesize it so that we can then look at social media data and ask questions of that. So I began my journey by looking at these kind of data sets and asking these kind of complex questions. And as part of that, we've then gone on to look at the NAP7, so the National Audit Programme with the Royal College of Anaesthetists. We've been looking at questions on a lot of long COVID and also patient safety issues. And as part of that, one of the questions that we've been asking ourselves is, what is big data? What is big qualitative data? How big does it need to be? And what kind of questions do we need to be asking of it? And for us, it's a lot of data, but it can be all types of data. So usually free text data in surveys, audits, social media data, interview transcripts, and more. And the reason why we need this qualitative data lens is because a lot of this data is quite complex. So I mentioned the NAP7 study, which I'll talk about in a minute, and essentially they had been doing that project at the Royal College of Anaesthetists for 6 years. We came in on the 7th year, and they said, Sam, we have 10,000 responses in this survey, and usually we have only 3 or 4 researchers that can ask questions of this free text data. And usually we can only look at 300 of these free text responses. We can't actually say, okay, if someone answered in this perspective, if they were lower, let's say they were starting anaesthetist, so I've got brain fog today, so I'm going to maybe make up a few words. But essentially, if they were lower in rank, would they have a different experience, and how would they communicate that? And so what they brought us in to do was kind of look at in multiple points of data, kind of look at a triangulation of that data and make sense of this. And then they said, well, once you've looked at that, Sam, how about we understand, well, what do your nuanced insights do to help us understand, well, what does impact look like? So that's what I'll show you a little bit about. In the process of kind of analysing this data, we at REAL have started to develop this method called the LISTEN method. And this is a way of using AI in a way of not completely relying on the AI tool and taking it at face value. It's making sure that we have rounds of team discussion, collaborative theme analysis that includes human and computational analysis, thematic analysis, developing a sentiment analysis framework that helps you kind of make meaning of things within a specific context that you're asking, and then going on to different rounds of team discussion. So you can see it's not trusting the AI as it is. And as I said before, this kind of started with looking at health worker data during COVID, looking at free text data, and then kind of branching out. And by doing this and by looking at things in these cycles, we were able iteratively to look at a collaborative analysis, kind of using different software tools, because as Axel said, this research is fairly young. I mean, I'm fairly ancient. I started looking at AI. So if you think about ChatGPT, the model today is 4.5, but I was looking at the model when it was 1.2, so years ago. I won't say how long, but essentially it's kind of looking at how we can kind of develop this analysis and ask questions and talk to developers and get them to kind of tweak things so that they can look at things from a social sciences point of view and a public health point of view. And so in terms of teams, we have started looking at data. Let's say this is social media data that we're looking at during the pandemic, where we had lots and lots of interviews and we had to kind of pare it down into 5 different themes. So we've got how did working on the front line affect individual mental health of healthcare workers? How were they supported by their organisations? What about their real life social network support? What was the wider context impacts, such as public support, lack of or proactive government response in that phase? And then during the beginning of the pandemic, we were looking at PPE because, as you probably all remember, that was quite key. And then from that data, then we were able to say, okay, well, what do we not want to look at? So we built these kind of code books and inclusion and exclusion criteria so that we as a team could then look at data that we took from interviews and from social media and then collectively kind of look to see, okay, what is an example of a tweet that we could include? What is an example of a tweet that we couldn't include? And we kind of go back to this. This was an iterative process, so we would kind of change this. And then this rather scary bit here is just part of a Boolean search term that we use. So from the analysis of that interview data, we then created a Boolean search term that we could use tools such as Pulsar and Brandwatch that we've been working with to then turn that analysis from the interview data into a lens that we could then look at the wider social media data and then ask questions of, well, when we interviewed healthcare workers, they told us this, but then in their private fields, in their audience, when they're speaking to the audiences, like on Twitter, where they only had 240 characters, versus YouTube videos, where they actually spoke in more depth about the mental health impact of losing colleagues on the front line, then what kind of data could we analyse and understand from this?
Sam, you've got about a minute.
Okay, I'll be really quick. So essentially, we use these kind of include, exclude criteria to kind of look at the data as teams, look at different themes. And then, as Axel was saying, essentially, you can see kind of different aspects of the data. So we're looking at what clusters of data look like and how close they are together or how far away they are together. So how, when people are talking about patient care, what are the connections to talking about COVID-19 response or PPE fatigue? And from this, we decided that, well, there were also questions of sentiment analysis. And then, of course, well, if you're using out-of-the-box tools, then essentially what kind of questions can you ask? You would need to create specific sentiment analysis frameworks that could look at the nuances of data. So here we've got an answer where people are talking about being affected by someone dying on in the operating field, and you can see we've got nuanced kind of sentiments, so positive, negative and neutral. So these kind of questions are the things that we need to be asking of this data. So not really just to rely on the tools as they are, but to apply that qualitative analysis context to it. That's me. Okay, I'll leave it there, and I think you're going to click on. Cheers.
Should we just mention what comes next?
Yeah.
Yeah, okay.
Shall I go ahead?
Yeah,
So next we have a pre-recorded presentation by Dr. Paulina Bondarodik, and in that presentation she's speaking about a project called Humble. She's in the early phases of this work, but it's interesting in part because she's using AI to better understand how essentially applied findings and actionable findings, insights can be gained from using AI. So we'll play that presentation now, and then we'll continue on to Axel's presentation afterwards.
Hello everyone, my name is Paulina and I wanted to talk to you about Humble, which is a human-centered method for bias-reducing algorithms with natural language processing or text analytics and qualitative analysis, and this is for improving health outcomes of underserved populations. So first I wanted to start from a case study that involved myself. So this is the feedback box from the NHS Test and Trace. NHS Test and Trace was the system responsible for managing the pandemic. And at the end of the service, each user was asked to rate the service from very satisfied to very unsatisfied. And there was a free text box saying, how could we improve the service? Now, this is just one quote I wanted to illustrate the issue. Too many phone calls received, all asking for the same information, expecting me to talk for 30 minutes whilst my father was dying from COVID-19 after having a hip operation, and then receiving yet another phone call asking me to talk for further 20 minutes. My father passed away today. So this is just one out of more than 500,000 responses that remains unanalyzed. So relating to this case study, I was given the impossible task and I also saw the potential. This is sort of the beginning of pandemic really, and I was a public health professional and I was giving a huge challenge to analyze the NHS Test and Trace free text data and provide recommendations for the program board extremely rapidly. So to date, using qualitative analysis, only 0.18% or 1,000 responses were analyzed. There was no resources to conduct such an analysis. I was in behavioral insights and I was asked to qualitatively analyze the data. So fast forwarding almost 3 years later, we managed to publish an analysis using artificial intelligence to manage this kind of large data sets using free text responses. And we conducted the analysis on 38,000 responses. And on the right-hand side, you can see just a visualization of the main issues. And the method is quite efficient and provides some quite granular findings of what were the main issues that users experienced. And we've also managed to compare human-only to machine-assisted topic analysis using this method we developed called MATA, and showed that this method can be quite efficient and comparable to human analysis. However, huge 3 learnings from that experience. It's too little. The most of the data really remains unanalyzed, and too late. Well, the insights came 3 years post-pandemic. They are published in journal, but it's too late to affect how the service is run. And too general. This is the most important point, because we know that those underserved were mostly hit by the pandemic, and we have this kind of data in the data sets that can show the differences between different stratification on the social ladder, what kind of experiences were there in the pandemic for those underserved. And I wanted to quickly zoom out and talk a little bit about the bigger problem. And the problems are that there are large volumes of free text data that could be analyzed using AI, but those same AI algorithms, if not developed mindfully, systematically, can exhibit biases leading to unfair or discriminatory prediction. And this can amplify health inequalities affecting underserved communities. So what I'm trying to do in Humble is to analyze and to develop a framework for text analysis. The main overarching point is at each stage of the analysis, I try to look at social inequalities and also to try to mitigate bias in the same instance. So I try to combine the two. I call it AI-human collaboration. Artificial intelligence, so speed, accuracy, and cost effectiveness, and bringing human qualities, so synthesizing and extracting meaning and contextual insights and understanding beyond the machines. And this can result in more responsive, whether that would be public health or healthcare. So these are the expected outcomes from Humble. First one is Humble Roadmap. So best practices guide for bias mitigation. I'm doing multidisciplinary review as we speak about what are the ways to mitigate bias. Will involve also the actual essential framework that combines natural language processing, qualitative analysis, and behavior science, and also insights, intervention, recommendation, and organizational change. In the first instance, I analyzed the user experience in NHS Test and Trace. I also wanted to look at NHS staff survey insights, and I'm also looking at different data sets, potentially in healthcare, that include free text and socio-demographics, so we can look at different social strata and look at bias mitigation to generalize Humble, to make it even better. It will result in enhanced engagement with underserved population, and also I develop Humble data tool for routine use in UK Health Security Agency, who is my collaborator. So it's extremely important for me to establish collaboration between healthcare professionals, social scientists, and data scientists, so we don't work in silos, because data science do not have a good answer to the bias question, and social sciences have been talking about biases for a long time, and historically we have more experience with bias mitigation. And as we know, one discipline does not have question to all the issues, so this is something I'm bringing together. So throughout Humble, I will establish different data assessment, data interrogation, algorithmic interrogation methods, using both quantitative metrics but also qualitative audit, bringing people to understand the algorithm, what's behind it, and to make informed decision about development. And also the output will also be assessed. There will be dual qualitative analysis approach where 2 or more researchers will analyze the data. And there will be a clear evaluation and improvement loop, including patient and public experts, representatives and stakeholders. So this project is for 4.5 years, and I started in February. At the moment, I try to develop a community of people who are interested in Humble, in developing this framework. And areas here is sort of, if you're interested or have expertise in health inequalities, ethics and bias mitigation, and critical approaches. You are a healthcare professional interested in making healthcare data more efficient and actionable. You are a social scientist and work in areas related to health. But also if you're interested in data science and technology and have expertise in natural language processing and machine learning, or you have any free text data that you might think of would be useful to include in Humble to potentially collaborate on analyzing this kind of data. And this means improving the model that I will be developing, but also having actionable insights provided, analyzed, interrogated, and providing recommendation. Please do get in touch. Thank you very much.
Okay, all right, okay, fantastic. Thank you so much. You get a real mix here of expertise and also interest and perspective. Can I just say, I really admire Sam's diligence and kind of like also the rigor, the scientific rigor and scientific nature of these talks. And I actually come from a different perspective. I'm an evaluator. I've got a company up in Lancashire. We're evaluating services, and I've also got an outfit at the medical school to do the same. But to be honest, if I was asked, what do you do? What sort of evaluations do you do? I would say quick and dirty. That's the sort of thing. And why? Because actually these are the things that clinicians come to me, they need to be done. They don't have 3 years. They have about 2 or 3 weeks to make a decision. And many of the organizations that come to us, even national organizations, say, oh, well, we get about 6 months. You know, can you do this? And by the way, here's about £20,000, you know. So that's the sort of thing, that's the sort of context in which you operate. And it's no disrespect to my wonderful colleagues in the South, it is also because we are not really blessed with many universities and research centers, as it were, in the North, necessarily, apart from, of course, Manchester. So the question is really, how can we do these things? How can we use AI to make or to support rapid evaluations? And as Sam rightly said, it's a balancing act. It's a very difficult balancing. I've been looking, in my company, I've been looking, of course, at saving time, speed, efficiency, resources. Okay? That's one of the things. And I have to tell you, the effect has been enormous. I've never seen something like that in any other context. But at the same time, you do want to maintain the rigor and the validity of the findings. That's really, really important. And how do we do this? Okay. One of the examples I wanted to show you just briefly is we've done a lot of interviews with a service, and we wanted to create a logic model. They asked us to create a logic model of an intervention you have to do, we need. And it was a national provider, a big provider in health. And we did the interviews, and we ended up with hundreds and hundreds of pages, about 500 pages of transcripts. Okay, that would have taken a RA days and days and days to actually get. So what did we do? Well, we cut corners a bit. Okay, and this is where the quick and dirty comes in, unfortunately. We cut corners, and we kind of like ask our wonderful ChatGPT 4, of course, we ask if we can upload this, can you actually create a logic model with us? Now, I would love to stand here and say this is a valid, a sort of like reliable version of the logic model, but I can tell you one thing. The AI would have taken days and days. This took 12 minutes with the AI. So you can see where the efficiencies are, okay? Where the cost savings are as well. Of course, what Sam said is absolutely right. The skill now lies in actually guiding that AI properly, what we call prompt engineering. That's really important. And I would love to see, and I had some great discussions with colleagues during the break. I would now really love to see the reliability studies on AI and qualitative researchers. I've been a qualitative researcher for a long time, and I can tell you, I'm impressed by this, but I still want to see that it's reliable. I still want to see that it's valid, it has a high validity. Okay, so prompting it rightly, sorry, this was a bit messy, prompting it rightly, actually on 2 of the questions, this came out within a minute. On 2 of the things, logic models are fairly structured, you can see that here. So you're really asking logic models, you're really asking about what are the inputs, what are the outputs, what are their outcomes and impacts, etc. And you can actually ask that question through a prompt, and what you get is the results. Okay, now this is slightly easier for AI, and the validity might be acceptable simply because it's actually a structured model. You're asking about facts, sort of like, you're not asking about emotions, feelings, etc. Okay, so there are really nuances in there, and Sam said that earlier on as well. Okay, that's the qualitative side of it. But then I was also interested, I'm a data analyst, I was interested in the quant side. Who's a quant researcher here? Who's looking at data sometimes? Fantastic, great, okay guys. And you will probably feel my pain when I wanted to know, can it actually do data cleaning? You probably spend, just like me, a lot on data cleaning. I mean, I work with NHS data sets. Data sets are really, really poor sometimes. And I'm going to give you a quick example if I can. Can I come out of this here just for a second? Okay, and we have a data set here. To me and said, oh, we really want to know something about comorbidities, whether they influence anything, And this is a data set. Don't worry, it's nothing. You can't see anything. There's no details or anything of patients. And he sent this to me. You can see the problem probably. Can you see this column here? Comorbidities. This is a mess, right? If you feed this into SPSS, nothing comes out of it. Why? Because what they've done is, well, they've taken this and they typed it into the data set. They said, oh, well, this patient has asthma, do I put asthma in? And then, of course, sometimes I spell asthma differently, et cetera, et cetera. And what you can see, several conditions, comorbidities are in one cell for one patient. This is impossible to analyze. So what we used to do, I guess you do the same, we used to disentangle these things. We have to clean them. It takes ages. It is so horrible. So what did I do? I thought about this, and I fed this in an AI, ChatGPT. And the first question for me was, of course, let's just see. I'm not sure what that is, but let's just see how it handles this. Now, I didn't clean the data set, and I didn't expect it to clean the data set. So let's see what it does. And you can see here, I'll be talking to this. I'm gonna upload an Excel sheet. We want to look at certain correlations, trends, etc., etc. I'm uploading the data to the Excel file now, and then I'm telling it, of course, as well what I'm looking for, and I'm using the various variables there. And fascinatingly, this is ChatGPT 4, of course. Fascinatingly, what I was really surprised by, it actually tells you every step of the way what it does, okay? And that was quite an insight. I thought it just goes away and then comes back with some results, This is, by the way, what I would deliver to my colleagues, clinical colleagues. I would go away and deliver results, and they would trust me. But it doesn't do that. It actually tells you, it also tells you and not just what it does, it also tells you what the limitations are. And it tells you where it can't go further, as it were. Okay? So this is quite significant. And then also it gives you options: clean the data, etc., etc. You know, can I clean the data? Should I clean the data? And then it tells you more about the statistical analysis. It can do certain things, but not others. And so if anybody here in the room thought we're going to be redundant in a couple of years, we won't be. We'll have to still guide this thing, as it were. In fact, we will probably spend more time, rightly, on the very complex things that are coming on our desk, you know, and that should be right. So I just wanted to give you a little kind of like a taste of this and sort of like a little flavor of this. It then, of course, goes through this, analyzing continuous variables, etc., etc. So it does a step by step, and it does also in ANOVA whatever you wanted to do, and more complex regression analyses. Okay, so what does that tell us? Well,
You've got just over 1 minute.
okay, what does it tell us? It tells us we can prompt engineer, but we need to carefully do this. What we need in order to do this right is training. We need to actually understand where we are, what we are doing, because as I said to some colleagues of mine in the break, people will do this anyway. Clinicians have already, some of my colleagues in the hospital, they're already uploading data sets to ChatGPT-4 and say, okay, can you give me this and this analysis, or can we do this? So we need to guide them, we need to upskill them, we need to actually make sure that there is reliability in this. Okay, this was our result, and there's no surprise because it was a simple chi-square. All right, that's it from my side. Thank you very much for listening, and let's see if you have questions.
That was great. Thank you so much for a couple of really interesting presentations. It was really great, certainly from my perspective, to see some applications of this, and just to get a bit of a better understanding of how it really works. In the process of evaluation and process of research. So I'm going to open to the floor. If there are any questions, it's quite a lot. So I'm going to go to the back. Person with a pencil. Yeah. Sorry, I'm so short. I can't make you see.
Thank you. Do you want me to sign up? I'm Paul Mason. I'm head of evaluation at the strategy unit. That was really, really interesting. And actually, you and I had a quick chat at lunchtime, and it was just so interesting. So thank you all. I've got a really.
If you turn it 45 degrees, the speaker's above you.
question.
No, other way.
Where do you want me?
The speaker's above you. That's why it's feedbacking. So turn the
I'm
microphone.
going to stand over here. Which reflects where my life is at the moment. This, what are or are there IG implications? So, I think, and I've got very sort of basic knowledge. I've learned a lot more today than I already knew. So, as I understand it, some of this software is hosted in the US, and so are there IG implications? And how do you go about securing consent from participants? I'm talking about when you're using qualitative transcripts here, and what are the consent issues? Given I've got a project that's locked in IG with NHS England at the moment because we're using in vivo that they're not happy about. So that's my question. Thank you.
Should we take a couple and then go? Okay, so there's this lady over here.
Hello, thank you. So I'm Elise Parkinson. I'm from Health Innovation East, and mine kind of follows on from that. So I was, my background is research and ethical issues, and so I'm listening to that, really intrigued as well as how we can use this in kind of an ethically informed way. Following on from that, I'm also interested about the IG implications, but also how do healthcare professionals, is that acceptable to healthcare professionals when you say, I'm going to go and analyse this predominantly using machine learning, how do they feel about that, or how do patients maybe feel about that? Is that acceptable to them?
There's a couple of great questions. So should we do the IG implications first? Who wants to take that?
Do you want to go, Sam?
Okay, thank you for your question. It's really interesting because we at UCL have been embroiled in the swings and roundabouts of ethics and IG depending on the different types of data sources that we analyse. So for example, looking at mental health questions of social media data, that is quite a difficult topic and it's quite a high risk topic to look at. So in that regard, we look at anonymising all the data in terms of using NHS approved scripts to take away all identifiable names, all identifiable departments that are mentioned, all links, anything that can be traced back to that person. Also for social media, when we're reporting, we make sure that we summarise all tweets or all different kinds of posts. In terms of looking at electronic health data, we also make sure that we look at secondary analysis. So we make sure that that data has already been anonymised. So we work with NHS England. So we look at data coming from, we have UCLH, in-phase data. Thank you. Datix data, so 10 years worth of Datix data. But we also make sure that we go through at least 4 rounds of ethics and IG, and then also making sure that we utilise looking at that on kind of NHS servers, so nothing is taken out. And any kind of external companies that we work with, they're all based in the EU. And if there are questions on how to access that data, we work with them to make sure that we have access to APIs, that they can come into the NHS, they can install it on our systems and make sure that nothing leaves it. So we rigorously kind of test this and visit it. We visit this problem with them at least every 6 months. So that's as much as we're doing at the moment.
Hi. So let me start with the IG first. So ChatGPT 4 has been really questionable in this, and I think we need to be precise what the actual problem is there, potential problem. If you're uploading data to ChatGPT 4, the question should be, is that data shared more widely, or does it stay on that computer, as it were? And in AI models, the real question is, will they use that data to learn further? What is in the learning pool? I don't have the terminology that you guys have, so I'm just going to call it the learning pool, okay? So that may have been the case at the beginning, so that's not the case anymore. You can close it. So actually the learning module is plugged on to the ChatGPT and will use the data and analyze the data, but nothing leaves the workstation. Okay, so that is fine. Microsoft Edge is actually exactly the same, and it has a button on it, a little click on it, and you can say close it. So it basically uses ChatGPT in the background. This is Microsoft, and it will not share data further, as it were, or it won't upload it into the cloud or anywhere else. You know, so that concern should be taken care of, and is taken care of, I think. Microsoft itself provides, so OpenAI is Microsoft, by the way. So Microsoft itself provides a safe environment. We all have it on our computers. So I would hope that this goes for the Microsoft Edge Copilot as well, which is the OpenAI, so I hope that is the case. Now, I had a really interesting question there. How do patients feel about this? Well, I don't know. I really don't know, because no one asked them. But you know what? No one asked them 10 to 30 years ago either. I work with 100 doctors in hospitals every year. They're doing their dissertation, master's program, whatever, and what they do is, on a Thursday afternoon, they send me their data. Literally, I hope you edit this out. They send me their data. It's patient data. Oh, can you help me with the statistics on this? This goes on a normal email, as it were. So, to say that we are at the moment properly and safely treating patient data in the way we should is an overstatement. But you're absolutely right. We need to, of course, inform patients and of course also healthcare staff, and find the right guidance and find the right regulations and rules to ensure that we're not treating it disrespectfully in any way. It's their data, it's the patient's data, it's not the NHS data, you know. So, but it's a really, really important part, and I think we have a long way to go still to understand where patients feel comfortable with this, with any evaluations. Or at the moment, you can actually take NHS data off the EMIS system, anywhere, and you can send it to somebody, Oxford, Cambridge, Manchester, me, and you can do these sort of, as long as they're pseudonymized, you can do these sort of evaluations, you know. So we need to inform patients better about this. You're absolutely right, yeah. So that's probably to that. Consent, I don't think we actually ask for consent. As soon as a patient walks into an NHS hospitals, it is understood that their data may be used for evaluations or quality improvement projects. Maybe we need to change that. Maybe we need to talk to them about this. Yeah, so it's not the answer we wanted, maybe.
Thank you. And just to add to that, that quite recently we have come up against this. So when we have to kind of conduct focus groups or interviews or use PPIE, for example, patient public involvement, thank you, engagement. Essentially, what we do is we have to write into our protocol and into any kind of consent forms that we will be using these methods on this data. And that's only just been in the last 8 to 9 months. And that's because UCLH and UCL have actually had legal action taken against them, saying that actually we don't give consent in some cases. So the landscape is rapidly changing, I've got to say that, especially in terms of AI, especially in terms of kickback from different departments. So, and different universities have different kind of IG rules. So, for example, I'm not going to name names, but a couple of Russell Group universities that I've used have just basically said, well, yeah, social media data, you can quote what you want. And then other journals that I've gone to have said, no, actually, we want you to take all of this out. We want to make sure that you have ethics approval from this date, and if you don't, go back and get it. So there are things that are changing, which I think, in a way, it's great because patients' data is protected, but then also for the rapid field, things aren't so rapid because it will add months and sometimes years on the data collection and analysis.
Okay, that was a couple of great questions. I think we've probably got time. I'm going to take one more question. Maybe we can. Okay, to the person.
It wasn't so much a question as an observation in terms of patients being asked, and particularly because one of the themes was underserved, and of course people often select in on data. And so just anecdotally, I'd just like to mention that in terms of the recent opt-out NHS and patient data, I'm a member of, I'd say, about 3 or 4 large WhatsApp groups, so purely anecdotal. In terms of my very large black women's group, 100% decided and were messaging about opting out. In terms of my Asian Fire Service Association, which is a balance between Caribbean, African and Asian people, there was about maybe 75% were having that conversation. In terms of my, what I call my church ladies Surrey group, the conversation never arose.
Yep, sure.
I find that really fascinating. I find that, thank you so much for your observation. I find that really fascinating because we're talking about biases as well. You know, we're actually replicating biases, etc. Interestingly enough, the biases are replicating what we do. So it's not that it's worse, it's actually us as doing that in the first place. So we're judging it by a benchmark. But this is really important because we need to ensure that communities are not disproportionately opting out, as it were. Otherwise, we're losing that data. Another simple observation about, I think 40% or so, off the top of my head, the Economist report that recently, 40% of the young people up to 25 don't have a GP. If they don't, in this country, by the way, if they don't have a GP, we don't have their data. We don't have their care data, we don't have their utilization data, so we actually planning services on the basis of a huge data gap. You know, so these are really important issues, and I know you probably just as concerned about these things as well. So we need to ensure, and that's up to us. That's not the AI. That's really up to us to ensure that people, communities, are represented.
Thank you. And just to add to that we have noticed that there are communities that are opting out, and it's about trying to help them understand how their data might be, or will be helpful in terms of mitigating biases. So I'll give you one example. My work with the Oxford Vaccine Group, we were looking at vaccine hesitancy in Brent and the underserved Afro-Caribbean and Portuguese and also other migrant communities. And we actually had to kind of get them in groups and focus groups and say, okay, we actually want your input. We understand that a lot of you aren't registered with GPs and maybe hesitant about what the effects of vaccines are having on your bodies. There are kind of historical trust issues, etc. But bringing them to the table and getting them to understand that we are asking valuable questions that we're hoping that will serve them. And then having that longer conversation means that they're then able to kind of have more impact and then help us mitigate that bias. But also they pull us up as well and they say, well, actually, I spoke to you 6 months ago, what's the result of this? So we have to have follow-ups with them. And I think it's bringing people to the table and kind of helping them understand what these kind of questions are that might help.
Okay, right, I'm conscious of time, so I'm sorry, we might have to take other questions outside, but I'm sure our lovely speakers would be very willing to talk to you about it. So I think we have one, maybe we can take Chair's prerogative just to ask one final question, because I mean, I think some of you will, like me, have been quite inspired by the talk today to perhaps go away and use AI in their own work. So can you very quickly, what is your top tip to the audience if they want to go away and start using AI in their own work?
Top tip, it all is in prompt engineering. It's really important that you ask the right questions because it actually learns with you. If you're using it as a Google search, forget about it. It's bad, you know. So you need to enter a conversation with it, and trust me, it talks back to you. Okay, that might be the scary bit.
And in terms of prompt engineering, again, if you don't know the question to ask it how to ask that question. So sometimes I'll say to it, I have this data set and it's really complex and you've not given me a good answer. Can you tell me how I can get a good answer out of you? And more times than none, it will give you a really good way to kind of be a better prompt engineer. And just one last thing, some really good tools that are good for academic and public health research. There's one called Perplexity. And that employs both Claude AI, which I think is better than ChatGPT, but there you go, Claude AI and ChatGPT models, and it allows you as academic departments to just kind of go in, ask questions. It understands how to look at not only academic data sets, but public health data sets, etc. And then lastly, one more thing. On my slide, there was Infranodus, so INFRANODUS. That is a freemium, that's like €9 a month. Again, it looks at the data and it tells you what's missing. So it will say, what's the structural gap? What are the questions you can ask of this data? There are lots of free YouTube tutorials as well that you can look at.
So helpful, thank you.
Okay, so can you join me in thanking the speakers?